All right, welcome. Today, we're going to step into the shoes of an ER detective and crack two really high-stakes cases. The challenge? You've got two patients, one critical symptom, and two completely different life-saving moves you got to make. Okay, so I want you to picture this. You're in the ER. The doors just fly open, two people get wheeled in, and they're both gasping for air. Literally can't breathe. What you decide to do in the next couple of minutes, well, it could change everything. So what's your first move? That's the big question we're going to tackle today.
Okay, so here's the plan for today. We'll kick things off with these two critical calls. Then we're going to dive deep into our first case, the post-op patient, and solve that PE puzzle. After that, we'll switch gears to our severe asthmatic and crack the asthma code. And then we'll wrap it all up by boiling it down to one single super powerful rule that honestly applies to just about any emergency.
All right, let's get right into it. The challenge here is pretty clear, right? You've got two patients, both showing up with this severe shortness of breath, what we call dyspnea. But, and this is the key, the cause is totally different, which means the cure has to be different. Choosing that right first-line treatment, well, it's everything. Okay, time to open up our first case file. Imagine the patient is right there in front of us. And yeah, that clock is ticking. Our detective work starts right now. So, meet patient number one. He's a 55-year-old guy who, out of nowhere, just can't breathe. And right off the bat, we get our first major clue. He had a hip replacement just 10 days ago. Now, you have to know, major surgery like that is a huge risk factor for blood clots. That one piece of history, it immediately shoots one specific diagnosis right to the top of our list. Okay, now look at these numbers. They're basically painting a picture of serious distress. His heart is just racing at 120 beats per minute. That's some serious tachycardia. He's breathing way too fast, 28 breaths a minute. We call that tachypnea. And his O2 sat, it's down at 88%. That is dangerously low. His body is just screaming for oxygen that it can't get. And then we get the evidence that just cracks this case wide open. First, the D-dimer is elevated. That's a big flag for clot. Then the ECG shows that classic S1Q3T3 pattern. That's a very specific electrical signature that screams right heart strain, which often points right to a PE. The Doppler ultrasound, it confirms the source, a deep vein thrombosis, a DVT, in his leg. And then the final smoking gun, the CT scan. It shows a large clot, a pulmonary embolism, just lodged in the artery of his lung. Boom, case confirmed. So, we've got our diagnosis. We know what's wrong. But that's only half the battle. Now comes the most critical decision of all. What is the single most important first move we have to make right now? So, good on your clinician hat. You got all the evidence right in front of you. The patient is technically stable, but he's in a lot of distress. What do you order this second to save his life? And the correct answer is administer low molecular weight heparin, or LMWH. This is an anticoagulant, basically a blood thinner. What it does is immediately get to work to stop that existing clot from getting any bigger, and just as importantly, prevents new clots from forming. And understanding why this is the right move is absolutely crucial. LMWH is the standard of care for a stable PE patient like this one. Now, the common traps here are treating him like he's unstable. Those clot-busting drugs, thrombolytics, you save those for patients in shock. An IVC filter, that's more of a backup plan. And just observing him? No way. That's not a treatment, it's a dangerous gamble you just can't afford to take. Yeah, let's be super clear on this. Thrombolysis is an incredibly powerful tool, but think of it like calling in the bomb squad. You only use it in the most extreme life or death circumstances, like when the clot is so massive that the patient's blood pressure has totally crashed and their circulation is failing. Our guy, he wasn't there yet. That's why heparin was the right call. All right, so case number one is solved. Now, let's totally clear the board and pivot to our second patient. The main complaint is exactly the same, can't breathe. But the clues, well, they're going to lead us down a completely different path. So let's meet patient number two. She's a 40-year-old woman, and she has a known history of asthma. And here's the big glaring clue. Her usual rescue inhaler, the albuterol, it just isn't working. That tells us right away that this is serious and it's escalating way beyond her normal control. Now, take a look at her vitals. Again, we're seeing that tachycardia, the fast heart rate, and tachypnea, the fast breathing. Her oxygen is dropping down to 90%, so her body is working incredibly hard just to get a breath in. Now, on the surface, the signs of distress look a lot like our first case, but the underlying cause is totally different. This isn't a plumbing problem like a clot in a pipe. This is an airway problem. And our investigation confirms it pretty quickly. When you listen to her chest, you hear wheezing, and you can tell there's very poor air movement. Her lungs on the X-ray are hyperinflated, which means they're full of trapped air she can't exhale. The blood gas shows respiratory acidosis. She's retaining CO2. That's a really bad sign that her body is starting to lose the fight to breathe. But the most damning piece of evidence? Her peak flow rate. It's critically low, at 150. This isn't just an asthma attack. This is a severe, life-threatening exacerbation. Okay, so the crucial point here is understanding the difference. With asthma, you have to distinguish between immediate rescue therapy, stuff that opens the airways right now, and long-term maintenance therapy, which is meant to prevent future attacks. And in an emergency like this, only one of those matters. So you're right there at the bedside. Her airways are clamped shut. What is your immediate move to force them open? The correct answer here is a combination therapy, and you're going to give it through a nebulizer. It's a short-acting beta agonist, or SABA, paired with something called ipratropium. This two-pronged attack gives you the fastest, most powerful bronchodilation to get those airways opened back up. And the logic here is just perfect. That SABA and ipratropium combo is the absolute cornerstone of acute treatment. The common errors? They all involve using the wrong tool for the job. Her daily maintenance inhaler? Way too slow. Magnesium? That's a second-line treatment you try if this first step fails. And ventilation support? You reserve that for when the patient is clearly tiring out and about to go into respiratory failure. And just to be absolutely crystal clear on this, her daily ICS/LABA inhaler is fantastic for preventing attacks, but it's not for stopping one that's already raging. Using that in an emergency is like trying to put out a house fire with a garden sprinkler. You need the fire hose. And in this case, the fire hose is that nebulized SABA. So we've cracked two very different cases. What's the big takeaway from all this? Well, it really boils down to one simple but incredibly powerful idea: the first-line treatment rule. Think of it as a framework for clear, effective action in any emergency. This right here is the first-line mindset. It's 4 simple steps. Step 1, assess stability. Is the patient stable or unstable? Because that dictates everything. Step 2, confirm the diagnosis. Use your history, your exam, all the key tests to figure out what's really going on. Step 3, deploy first-line therapy. Give the established, evidence-based initial treatment. Don't get fancy. And finally, step 4, reserve other options. You need to know why other treatments are second-line or for maintenance or for specific situations. This framework is what keeps you focused when the pressure is on. Because at the end of the day, in any emergency, the difference between a good outcome and a bad one isn't just about knowing a long list of treatments. It's about knowing exactly what to do first. So the question I want to leave you with is this: what other first-line versus trap scenarios are out there? And are you ready to make the right first move?